common denominator amongst all four. What you really need to know about these seronegative spondylopathies is this, that once again, they do cause inflammation in the body, and this inflammation causes joint pain. These joint pains are defined in two aspects. One is axial, meaning it's in the spine itself, and then obviously it's peripheral, meaning other joints throughout the body. There are four altogether, and these four are the ones that are really important. The first one, which is the most important one, is this ankylosing spondylitis. You'll see how this presents and how this is different from all the other ones. And then something called Reiter's syndrome, or at least it used to be called Reiter's syndrome years ago. Just recently, in the last 2 years or so, they changed the name of it. They started calling it reactive arthritis. And you'll see why it's reactive in a few minutes. Then we have something called psoriatic arthritis. This gears more towards a cutaneous manifestation, meaning skin disorder, patients who have psoriasis, and they tend to have those patients, and only those patients tend to have joint pain. Then last but not least, a whole different type of arthritis that we can see. These patients have this arthritis because they have GI problem. And it's called entropathic, or as we like to call it, arthritis of colitis. Patients who have any kind of GI problems like ulcerative disease, ulcerative colitis, Crohn's disease, and things of that nature. So you can see how all these things vary. And then most importantly, how we define what we said initially. Some are on the spine and some are peripheral. So we start talking about arthritis of colitis. This is obviously peripheral. So let's kind of get into it. Well, the etiology, as anything, as we mentioned before, is hard to define and it's unknown. But we do know out of these four neuropathies, one of them is definitely an infectious agent. In this case, a negative bacteria or gram-negative bacteria, which is a Klebsiella pneumoniae. That's the one that tends to be the bacterial agent, and that's the one that's connected to how everything takes off. All the other ones we really don't know, but there is a genetic predisposition. Now, I just need to stop class for 1 second and tell you so. Last class we had, some people didn't show up. Others came in like 40 minutes in class. They asked me to take attendance today. I'm not sure if I should take attendance or not. So if there's somebody that you know that's not here right now, text message them to call them. I'm going to give you like 20 minutes or 15, 20 minutes, then I'm going to take attendance. Because they asked me to take attendance. Because I think last class, 2 people didn't show up, or somebody didn't show up, or it was a big problem. I shouldn't be telling you this, even though it's being copied, but I'm letting you know absent. I'm not trying to give you a hard time, but you just got to show up to class. This is not St. John's where you don't show up and the program is ready to close down. Okay? You got to show up here. All right? Back to what I was saying. Initial triggers are there, but for ankylosing spondylitis, Klebsiella pneumoniae, which is the reactive arthritis or Reiter's syndrome, that one has a bacterial agent, and it's proven that this bacteria is the one that triggers off everything. All the other ones really don't know what's causing them, but there is definitely a genetic predisposition. Now, they vary axial, peripheral, in the GI gut, psoriasis, and so forth, but there is a common denominator amongst all four. And that common denominator is this antigen called HLA-B27. HLA-B27, HLA-B27. And this one, you'll constantly see it coming back on the boards. All the time, it always pops up. Okay? So there is a relationship amongst all four, and it varies. So if you look very carefully here, you'll see ankylosing spondylitis 90% of the time these patients will have it. And then as we break it down 50, 50, 80, and so forth, and off we go. Okay? Now, this HLA-B27 is directly connected with gram-negative bacteria. We find that some of their RNA and DNA structures that they share tends to be the same, and that's the reason why. When it comes to rheumatology, everything is at a really, really early stage. Truth was, rheumatology was kind of like really slowed down. And then COVID comes around and everything sparks. Meaning, rheumatology really took a new shape. Everybody got the COVID shot, so they were infected with COVID, and all of a sudden, joint pains everywhere. Rheumatoid arthritis is significant now. I mean, everybody's having joint pain, and they're RA positive, and then everything else that we spoke about. So you will see a lot of this on the board because it's almost like a new form of medicine that's really, really sparked itself. All right, so now that we know a little bit about some of them, on all four, we know that the HLA-B27 is the key denominator here amongst all four. Let's talk about each one of them. And most importantly, how you're able to tease it out on the exam. Okay, so let's start getting started. Let's get started. Ankylosing spondylitis, the first one we need to speak about. These patients will come in, and some of the complaints they have is very unique, and that's how you'll know. They'll tell you that they're having some pain in the lower back, or they're having pain in their lower spine. And if anything, they might tell you, I'm having pain in my butt. That's what usually gives it away. The reason why it's giving it away is because the pain has to start there. It has to start the iliolumbar area. That's where the inflammation starts, and then it starts to work its way up. We find these patients also have something called gel phenomenon, which we have mentioned before, that in the morning is when it's the worst, meaning the body's very stiff in the morning. When they get up and they start moving around, but there's some activities, things start loosening up a little. That's not saying that the spine loosens up. What we're telling you is that the muscles around it start to work, they start loosening up, and symptoms get a little bit better. That doesn't mean the symptoms go away. So what's actually happening here is this. Patients having decreased range of motion. And what I want to mention is it starts off at the iliosacral area, and then it works its way up. So if you have pain in the butt, then the pain starts going up the spine. And that's key here. The key here, it starts off low, and then it works its way up. That's the first symptom that they'll have. They'll tell you I'm having pain in the butt and in my lower back. And then some other ones will tell you, hey, I'm not only having that, but I'm having other issues. It feels like I have pain throughout my body in the sense that wherever there's a ligament or tendon that inserts to a bone is where they'll complain of pain. Obviously, they're not going to tell you that. No. But they'll say, it hurts here, it hurts here, it hurts in my Achilles area right there. And that's how you might know. You might say, oh, well, that's exactly where the ligaments and tendons are attaching to the bone. It's a very vague complaint. Those complaints will kind of present like this pain all throughout my body. And then other times, taking a deep breath in. Once again, same concept. You have ligaments and tendons that wrap around the rib cage and so forth. Therefore, that presentation might be okay or understandable. That's not enough, which it shouldn't be enough. The boards will be very vague about it. Then something else that you might want to look at is this. You'll ask the patient, say, I think that you're complaining of pain in the butt, going up your spine, and the vague complaints. You know what I really want to concentrate on? I want to concentrate on your eyes. Do me a favor, take off your glasses. The patient will take off their glasses. What you're going to look for is this inflammation in the middle layer of the eye, especially the color part of the eye. You're going to see this like this tissue buildup around the ciliary body. And believe it or not, that's one of the most common presentations that you can actually visualize patients who have ankylosing spondylitis. Now, that doesn't mean that right when it happens, at the early stages, you might see it. No.
Trauma alert to the emergency room. Trauma alert to the emergency room. Trauma alert to the emergency room.
But this is the one that since most people have it and you're able to visualize it right away, you're able to pick up on it. So the boards will ask you that. They will probably give you pain in the butt, going up your spine, alongside with that, this little inflammation in the middle layer of the eye. That's number 3. Second one, very vague. The third one with the eye makes sense. Let's move on to the 4th complaint that you might get. Once again, you might see this on their back depending on what stage they're in. This picture is key here. Because what you'll tend to see is the paravertebral muscles, and they're just not functioning as well. They're not as strong as they should be. They'll have a lot of spasm there. What you will see is this, the loss of lumbar lordosis, okay, significant dorsal kyphosis, and cervical spine flexion. This is obviously seen at the late stages. On a presentation, on a physical examination, they'll be easily picked up. But on a case vignette, it's different. You have to read this through to understand that it's linked with ankylosing spondylitis. And the way to really do it is sometimes they might not even mention that, but sometimes I've seen case vignettes indicating the patient has a stooped shoulder appearance. Or what they'll do is the patient is unable to see you, and what they'll do is they'll flex their knees in the sense that the picture they're presenting is, since the patient has such cervical spine that comes out here, they're gonna have to bend their knees to look at you. The case vignettes might present that. I've seen it because I've done a lot of ER medicine, even though patients are not coming in complaining of this, but I know they have ankylosing spondylitis because of the way they present and then the way they just talk to me. They'll bend their knees so I can see their face, and I'm like, oh, this patient's got ankylosing spondylitis. Okay? Then they might ask you, hey, what might you do on a physical examination to possibly get a diagnosis? You're gonna say, well, I think I know that. It's something called a Schubert's test. Very, very simple. You go find L5, lumbar spine 5. You make a little mark on the L5. Then you ask the patient, hang tight, I'm going to go down about 10 centimeters or so. I'm going to make another mark just below it. Then you simply can ask the patient to do is flex. As they flex down, okay, if they're able to get 15 centimeters or so above, then that means they have good flexion. In somebody who has ankylosing spondylitis, the distance is usually less than 13 centimeters. It's a very simple test, very inexpensive test, but they always mention it on the boards. But you have to know these numbers because that's key. And what it looks like is very simple is this. You don't need any radiology. You don't need to do any kind of testing. And just simply asking the patient to bend over. The reason why is in the lumbar area, you should have enough flexion, just like you should have enough flexion in your cervical spine. And when that lack of flexion is there, then the Schubert's test is positive. And that just simply indicates that there's not enough range of motion. Okay? And then with the eyes, the pain in the back, and the butt, you're starting to get your differential diagnosis to start narrowing down. And that's what we want you to do. Okay? If that's not enough, then we're going to move on. All right, the Schubert's test is positive. You got something growing on your eye. You're complaining of pain in your lower back. It's starting to go up your lower back, starting in the butt. What I want to do is this. I've got a good history. I got a good physical on you. I did something called a Schubert's test that indicates that you have lack of flexion in your lower back. What I really want to do is I want to get some blood work on you. And this blood work is probably going to be a combination. One is going to be ESR levels, CRP levels. Those will let us know that you have some inflammation in the body, and they should come back elevated. But the one that really should bring it all together is an HLA-B27. All the significant clinical findings alongside with an HLA-B27 should be enough. You might say, well, what happens if that's not enough? HLA-B27, you told me yourself, Zeb, that it's only 80% accurate. Right there. I'm sorry, 90% with ankylosing spondylitis. Can't you miss the 10? Yeah, absolutely can miss the 10. But my clinical findings should help me. Well, they're all there, but the insurance company wants to know that if HLA-B27 is negative and all the clinical findings are there, we need you to work as a practitioner. I need you to give me a diagnosis. Not a problem. Last but not least, I'm going to go and get an X-ray. I'm going to get an X-ray of the LS spine, lumbar sacral spine, LS, lumbar sacral spine, and on the lumbar sacral spine is what's going to give it all away. What you're going to actually see is something called squaring of the vertebral bodies. You're going to start seeing pseudo-widening of the sacroiliac joint, marginal erosion, and then it might indicate joint fusion. They might not give you a picture, they might give you a picture. They might just tell you this is the impression that we've gotten on the x-ray, and you should be able to put that together. Other times they might say bamboo spine ascending. Some radiologists might read it that way. They might read it this way. It's up to you. What all this means is this. You're having fusion of your spine. It starts from the sacroiliac joint and it slowly starts to work its way up. If you notice here very carefully, there is no vertebral bodies, and in between the vertebral bodies, we don't see the cartilage and the spacing in between. Okay? We don't see the spacing in between. And what you're actually seeing is two bones that are starting to fuse together. And then if the two bones are fusing together, there should not be any range of motion. There just isn't any. None. You get the idea? Move on. Any question on that? History and physical is key. If the physical examination is not enough, then HLA B27. If you fall within that 90/10th, then you're going to get a false negative. And if you're still convinced, then an X-ray will put it all to rest. Okay? Even at an early stage, you will start seeing changes on an X-ray. That's what's key. All right, let's move along to the next thing, which is okay. The next thing is something called Reiter's syndrome or reactive arthritis. Once again, the epidemiology is pretty straightforward here. We're looking at young, healthy males or females. And once again, you're going to start seeing inflammation that's causing joint pain. Usually tend to start seeing it in the third decade, usually in the 30s. So, if these patients are young, healthy, active in their 30s, then there's some things that you're looking for. You're looking for venereal infections like STDs. And that's not it. I'm not saying people who have reactive arthritis are sexually active, healthy people that have STDs. No, we're not talking about exactly that. It can simply be a GI issue also, like gastroenteritis by salmonella or shigella poisoning. That can do it. If you have an infection, that can go and trigger this off. The reason why is because they're all what? Gram-negative bacteria. So these patients will present very, very clearly. Now, it could be an incomplete triad, or most of the time it's a complete triad. And what that simply means is I can't pee, I can't see, and I can't climb a tree. That's the way I've learned it, and I think that's the way you should learn it. You'll never forget it. If you can't pee, you have what? Arthritis. If you can't see, you have conjunctivitis. And if you can't climb a tree, then you have arthritis. And that's the way it's done. But once again, you don't need to have all three to get a positive result. Sometimes it's one, sometimes it's two. But on the board, they should give you a complete triad. And that's what usually gives it away. On physical examination, the patient has this, this, and this. You're like, oh, that's very easy. Reactive arthritis. All right, tell me how you want me to go and answer this question. And then your head should be on a swivel. All right, I got this. I know the HLA-B27 is going to be positive, or I know it's going to be there, but is there anything in between that I should look for? Well, let's look for some of these symptoms. Post-venereal disease or post-gastro infections. Once again, purulent discharge, vaginal discharge, dysuria, and so forth and so forth. Since it could be an STD, then gonorrhea, chlamydia might be present. And they will tell you that. All right. Vague. No problem at all. What do I really need to know? What's really going to be really popping out in the case vignette? Well, we had said that you can't see and you got conjunctivitis. At this point, if you don't know what conjunctivitis looks like, did you guys have ophthalmology yet? Not yet?
Next month.
Next
Like
month.
July.
Are you gonna, which semester is this?
Second. The scheduling is,
Yes, weird.
yeah,
Okay.
I think like once this ends, then we start.
Okay.
Yeah, Fridays.
No problem. So you will see conjunctivitis as you learn ophthalmology. Normally, what the problem is, you have some crusting around the eyelids because of bacterial infection. As you sleep, the bacteria starts growing. When you wake up in the morning, there's crust all around the eyelids because the bacteria is constantly growing. Okay. When it comes to other problems, ankles, feet, knees is where the problem is. These are patients where they're complaining of some joint pain. That's not enough. What really stands out is this. You're going to start seeing something called sausage digits. You'll ask the patient to take off their feet, take off their shoes, and on their feet, you'll see these sausage digits. You'll start seeing certain phalanges, and they're starting to diffusely enlarge. That might help you. Other times, you're going to have this inflammation where the bones insert, like Achilles tendon. or tendonitis around the Achilles. That might work. If that's not enough, you ask the patient to drop their pants. If they're male, then you're looking for exactly this. You're looking for lesions around the glands of the penis. Those will give it away. If that's not enough, then something called writer's nails. They're thick, yellowed nails, and they're very thick. I'm going to show you a picture in a second or two. These are all the clinical manifestations that you start looking for in the patient. If not, the case vignette will give you one or two. They'll absolutely give you one or two. The one that they always give is the triad. Okay? Very rarely will you have like the glands of the penis and so forth. But I have seen a few on the fingernails. These writer's nails that I talked to you about before. They're thick, they're plaque, and they actually start to get brittle and fall off. Will they present that to you? Maybe, maybe not. Remember I said where the Achilles and the tendons kind of interact with each other, at least where the Achilles tendon is? Well, notice here, this is normal, this is inflamed. Normal, inflamed. I doubt they'll show you that, but it is what it is. Okay? All right, history is important. I'm having a hard time seeing. Every time I wake up, I'm crusting around my eyes. Every time I pee, it burns. I'm having some joint pain, especially around my Achilles tendon. All right, your history looks good. Let's do a physical examination. Let me drop your pants. I'll do a check to see if you have any lesions on the glands of your penis. Let me look at your fingernails. All the physical examinations start coming together. All right, I've got a good history. I got a good physical examination. Let me go ahead and do some blood work on you. The first thing that you should do on these patients is obviously cultures. Urethral cultures to see if anything comes back positive. Gonorrhea, chlamydia, and so forth. And then once again, HLA-B27 should help start putting everything together. And because some of these patients have an STD, and HIV testing and syphilis and so forth is only warranted. Now, question is this, is that all? No. X-rays seem to be a good test to wrap up these diagnoses. For ankylosing spondylitis, we got X-ray of the LS spine. That helped us significantly. Can X-rays help out here? Yeah, they can. And most insurances will say, you know what, do an X-ray. Rheumatologists say, nah, that's part of our workup. Let's do an X-ray. So you'll get an X-ray depending on which joint it is that you feel that the patient's complaining of. And then you're going to start seeing something called bone spurs that start inserting exactly where the tendons and the bones kind of meet. So one of the largest tendons in the body is where? The Achilles tendon. One of the strongest ones. So let's get an X-ray there. What are we looking for? Bone spurs, right? Well, let's look at the bone spurs. Where do you guys see something that's abnormal here? How about here?
Yeah.
Imagine walking on this. That's got to be painful, right? Some of you ladies who have those nice 3-inch lift kits, this is going to poke you. Ah, it hurts so bad. And then females are the ones that really say, no, my feet are killing me. Every time I walk, I feel like I'm walking on nails. And that's the way they're presented, especially when I was in the ER. Like, oh, it hurts so bad. Every time I walk, did you fall? Did you hurt yourself? No. And then, boom, off it goes. All right? Let's move on to the next neuropathy called psoriatic arthritis. And that's pretty straightforward, right? Psoriatic arthritis, patients who have what? Psoriasis. And around this time of the year, this becomes very famous, and then you're going to start seeing a lot of what? A lot of infomercials to start coming into place. And they talk about psoriatic arthritis and how all these medications are readily available to start treating not just psoriatic arthritis, but some of the other spondyloneuropathies that we spoke about. But for some reason, psoriatic arthritis really kind of comes up to play, especially around the TV, around this time of the year, because golf is starting, the Masters is starting, and so forth, and they start plastering this everywhere. So, patients who have psoriasis will tend to have arthritis. They develop about 5% of the patients who have psoriasis will get psoriatic arthritis. Males and females are equally affected, but we tend to see this in the ages between 30 and 55. Will this be on the exams? No, this will not be on the exam. But the reason why I put this on there is because when you start seeing patients with psoriatic arthritis, and the case vignette comes up, they usually will tell you there's a 34-year-old, there's a 35-year-old, a 40-year-old who presents into your office. And most of these case vignettes start that way. Therefore, it is important to capture these. Because you want to be a good test taker, this is the kind of stuff that pops up, and I honestly mean. All right. Why do I have this guy on here? What's his name? Nobody bangs off here. Phil. Phil what? Phil. What? Oh, it is where it is. Where is it?
Right next to the right side.
All right, Phil. So in the past, I used to speak about Phil, and everybody thought I was talking about Phil Lowenstein. And it got really bad because one of the things that you have to do is ask Phil to drop his pants, and and it got really bad. But the reason why I'm telling you this crazy story is because this is going to help you memorize this, and it's going to burn this into your brain. I'm not trying to be a smartass. I'm not trying to give you a hard time on a Friday at 12:30. No, I need you to learn how to memorize this stuff. I'm a visual learner, so if I hear something stupid, like the conversation I'm going to have with you, it will always get embedded into your brain. Let's get started. All right, so we know that there's some arthritic pain here, secondary to inflammation. Exactly where it is, well, ankles, knees, wrists, hands, they're all get affected. Hands really do take a really big hit. And then once again, Phil comes into your office, say, Phil, I need you to take off your shoes. Why? Because I'm going to go and check to see if you have any sausage digits. The same thing that I saw for Reiter's syndrome. Let's see if your feet and your toes are obviously affected. If that's not enough, you're going to say, Phil, I'm going to need you to take off your gloves. I know you have your gloves on. You're going to go golf today, but I need you to take off your gloves. Why do you need me to take off my gloves? Because patients who have psoriatic arthritis, their fingernails are usually affected. Their fingernails do not look good. There's nail pitting, ridging within those nails. This you will see on a lot of the case vignettes on the board that will talk about psoriatic arthritis. This is constantly spoken about all the time. And then axial involvement, a complaint of back pain and so forth, but those are very vague. If that's not enough, not a problem at all. Phil, I'm going to need you to take off your glasses. As you take off your glasses, you're going to go and start looking for other things. You're going to start looking for inflammation around the episclerosis area, okay, in between the conjunctiva and the sclera. Just around that area is where you're going to start seeing some discrepancies. And what I mean by that is this right here. You're going to see this growth that starts popping up right here. You notice how it's fleshy at times. That is usually another great clinical manifestation for someone who has psoriatic arthritis. Okay? And then the one that's a true giveaway is obviously the patchy hair, the psoriasis that you tend to see over the skin. So, when these patients present, the one thing that you have to make sure is they have psoriasis. Once you conclude they have psoriasis, then all these extra manifestations are key here, especially this. And this is what the fingernails look like. You can see it, they're in horrible condition. I mean horrible condition. And then right here, look at psoriasis. You get the idea?
Is that a sausage?
Yeah, kind of. I mean, look right there. So you have a little bit of all of it in here. Okay. And this was also from accreditation. I stole it fair and square. So I popped it in. These are old pictures that used to be on the boards all the time. Yes.
5% of patients.
So the arthritic pain is what you'll see 5% of the time. But that's not to say that these manifestations will not occur. Okay. Here's another picture. Sausage digit. Look at the nails. They're completely eroded. And then if you look at the nails more in depth, notice how they're pitting. It looks like someone took a small little pin or some kind of small object and was just literally causing small trauma to the nail itself. And that could be great. But the nails are key. I can't stress enough how important the nails are. Here's a sausage digit Once again, you ask the patient to take off their shoes, and this is what you'll see. All right, we got a history, we got a physical examination. Hey, every time I come, I'm in the area. I feel like I have some joint pain throughout my body. Okay, and I also have a history of psoriasis. No problem. Let's do a physical examination. Then you can start seeing everything in place there. Okay? So the question comes into place: is what's the next thing you do? Well, HLA-B27, and we're on our way. That will help you. But if I'm right, the HLA-B27 is what? 50% of the time will come back positive. Fine. Is there anything else I need to do? Yeah, you need to get an X-ray. And the X-ray is key here. This is a very, very unique X-ray that you don't see anywhere. Okay? You're going to start seeing some joint space narrowing, marginal erosion, and bony perforation. Now, what does it look like? This is exactly what it looks like. And the way it's always written on the boards is pencil in a cup deformity. They'll indicate X-rays obtained. On the X-ray, the impressions were a pencil in a cup deformity with marginal erosion and space narrowing. Then they might show you. Now, if you look at this picture, you might say, what do you mean? What are you talking about? Pencil in a cup deformity. Well, here's the cup, and here's a pencil going in it. That's it. I know it's terrible, but somebody said it, and I've been learning it, and you should be learning it for the last 20 years. Okay? And the idea? You see the erosions right here. It should look like this, but this area of the finger is completely eroded. Okay. Here's another picture. Look at here, completely eroded on the sides, and it looks like a pencil going into a cup. It's completely unstable. I mean that, completely unstable. You take a swing at the golf ball, and all of a sudden your finger might fall off. Right? All right, let's do this one. I'll give you guys a 5-minute break. This is pretty short. So last but not least, we have something called arthritis of colitis. And this is obviously patients that have GI issues that are chronic, like ulcerative colitis, Crohn's disease, and so forth. These patients will also come in complaining of arthritic pain. Most of the time, they present with lower extremities, like knees, ankles, feet, and so forth. These patients could also have sausage digits and joint pains around, obviously, areas where the bones are meeting the tendons and so forth. And not often will you see this, and they will not present it, but 12% of these patients will present like ankylosing spondylitis. Even though it's 12, which is significantly a lot, never ever have I seen a board question that indicates this patient has arthritis colitis, and then they give you all the symptoms of ankylosing spondylitis, meaning the bamboo spine. They won't do that. They always separate them. Always, always, always separate them. But for those of you guys who go into rheumatology, you could see an overlap. Now, if I would ask, hey, if you raise your hands, you guys are going to go into rheumatology? Nobody will. None of you guys will. Half of you guys probably didn't even have heard of what rheumatology was. The truth was, you know what's crazy is, before we started this class, I had some students come up to me like, what is rheumatology? Like, what is that? And I'm like, all right, it's like, osteoarthritis and rheumatoid arthritis and so forth. And it's only right, but once again, it depends on what you like to do. I would hope that you will get out there and start chasing some money around, because if you do, rheumatology is amazing to make money. And I mean amazing to make money. Amazing. There's so much out there for PAs to make money independently from the doctor. If you want to know, let me know. I'll show you. All right. History and physical is key. They'll tell you that they have Crohn's disease, ulcerative colitis, and so forth. And then you want to go and get some blood work on these patients. HLA-B27, ESR, CRP will help you check to see if the patient's anemic. Why would the patient be anemic? How would the patient be anemic? What's that?
Loss of blood.
Loss of blood secondary to what?
Ulcerative.
Ulcerative colitis. Okay, we always tend to see that. So, X-rays and things of that nature, if they do have it, it'll show some changes. But if there's axial involvement, then you have to correlate that to ankylosing spondylitis. Everyone and anyone who has arthritis of colitis, they always get checked out and they always will get x-rays of the lower spine also to make sure that it's not overlapping with ankylosing spondylitis. Now the question comes into place, if you're paying attention, is, well, what about treatment? You've gone through history, you went through physical, you went through all the manifestations of what they should look like. You told us how to diagnose the patient. You never said anything about treatment, Zeb. Well, treatment is very different for each one of these four seronegative neuropathies. And what I mean by that is this. First things first, the common denominator is you should get physical therapy on all these patients. It'll bring down the pain, it'll make the muscles around it strong, especially in your lower back and so forth. NSAIDs, non-steroidal anti-inflammatory medications will help, and analgesics will help. But once again, you got to be very careful. NSAIDs and patients who have GI symptoms like GI bleed, it's a big no-no. You want to get sued and lose your license immediately? This is exactly what you should do. Then, okay? So please don't. Please, if you're on NSAIDs, if you have ulcerative colitis, Crohn's disease, if you have any kind of GI problems and so forth, please do not take NSAID. Do not take medications like that. They will ask you, if you do put them on there, you obviously get it wrong. But if you want to get sued, you give NSAIDs to someone who has any kind of GI complaints. Right? Next thing, steroids. They are helpful. They will work. Only certain patients. Once again, if you look, steroids will help for everybody else, but they will not help the patients who have what? Psoriatic arthritis. You give too many steroids for somebody who has what? Skin infections. They'll fine. They'll bring down that skin infection, but you have psoriasis flare-ups and so forth. Steroids will help. They will reduce the psoriasis, but the rebound flare-ups from once you start the steroids, it's going to come back really, really bad. So please, please, please keep that in mind. Okay? Please keep that in mind. Last but not least, there are new medications that are out there, and they do work, and I mean they work. Medications like Remicade, they are FDA approved, okay, for certain things, and they work very, very well. Depends on who gets them and how do you treat them. They work amazing. I think I spoke this to the last class also, but Remicade is a medication you give IV infusion, and you can take it. It works very, very well. Years and years and years ago, now probably about 7, 8 years ago, there was a young lady that was in the PA program here, and she had graduated. Her and her husband, I knew her husband, who was an ERPA. They moved up north to where Niagara Falls is, around that area. He got a great job there, and she wanted to do primary. She wanted to kind of kick back a little, but she went up there with him, and she started working at a primary care office. She worked for a primary care doctor that was fairly elderly, and she used to pretty much run the office. She did great, and she used to love rheumatology. So she had about 6, 7 patients up there that had all kinds of rheumatoid arthritis and all the stuff that we already spoke about. And she started treating them. Eventually, she had some patients that needed medications like Remicade because they had these spondyloneuropathies. And what she did was she reached out and she said, "Hey, can you, give me some guidance?" I said, "Yeah, I have a rep here that I know who does Remicade infusions. He'll give you a call. I'm not sure if he goes up that far, but he'll obviously give you everything that you need." Anyhow, he got up and running with Remicade infusions. She was giving Remicade infusions to the patients that she had. And then all the doctors up there who were kind of like elderly would start sending them all the patients for rheumatology. And then she started doing Remicade infusions and all these other new biological cell modifiers that are out there. And guess what? She's killing it. I think I told you guys the story already. Yeah. Doing so great. But once again, Remicade is approved for these neuropathies. So get to know them, and because you're constantly going to see them over and over again. Now, once again, Enbrel is another medication. Enbrel really is approved by the FDA for psoriasis. So you'll see a lot of Enbrel commercials out there that talk about psoriatic arthritis around this time of the year. All right? If you just have psoriasis, then obviously topicals will do. But if it is Reiter's syndrome, as we have mentioned before, where the agent is bacterial, then antibiotics is key. Okay? Antibiotics is key. So important. All right, let's take a 5-10 minute break, and then we'll come back. Listen, for some of you guys, I just want to kind of throw this out there. You guys pay a lot of money to be here, right? You pay a lot of money to be here. You guys all agree the money here is so much. I don't understand. I don't know if you're Parents are paying for it, you're paying for it, and so forth. When you're here, why don't you? Not, I'm sorry, I'm like looking at you guys, just close my eyes. But some of you guys are just like on your phones the whole time, and you're laughing and stuff like that. I don't know if you're TikToking or whatever you're doing, because what the stuff that I'm saying is really not funny. That's how I know that you're not paying attention at all. And some of you guys are just like constantly on your phones, and I don't know why. If I were told to pay $150,000 minimum, right, to come here, wouldn't you want to learn everything that you hear? I mean, what's that important? I don't understand. You're paying money to be here. And in the end, we're going to give you a piece of paper. That's all we're going to give you. You did great. Like, I see it all the time. When I'm here, there's some of you guys that just never paying attention. And I don't know why. It blows my mind. You're going to be done here like another 15, 20 minutes, and you can go home and TikTok then. Like, I don't understand. Like, why you here? Absorb it. Take it all in. Imagine if somebody came up here, took $150,000 of your money, and didn't teach you nothing. How pissed would you be? How upset would you be? You'd be like, I'm paying all this money. I'm here. Some of you guys don't even care. And if your parents are paying for this, or whoever's paying for this, and you're going to eventually have to pay all this money back, you'll see you're going to be paying this back for like 10, 15 years. You'll be like, I wish I was back here. And I'm going to tell you, I'm going to be honest with you. Once you guys get out of here, 2, 3 years from now, when you have responsibilities, kids at home, life insurance, health insurance, car insurance, you're going to wish you were back here. Because everyone that graduates after 3 years, like, I wish I was back in PA school, where I had nothing going on. I could just sit there and just listen to you guys and learn stuff. Honestly, like, at least like act like you're paying attention. Like just act like you. Hey, I'm just paying attention. All right, I'm sorry. Take 10 minutes and we'll come back. You all right? I'm done. Go downstairs. Okay. Then I come back. Go to the ER.
My question, if we're seeing person and she's not athletic, and she tried to be athletic, how do you doing things? I don't know what she do. And now she's at the follow point, so like she's here, my hand's like, oh, are you here? Like you come with me, like I can't move it. I'm crying. It should be like this. It was like I don't think yeah. Yeah. I heard it. You heard the snap. I stuck me. You're on the I was like, why would you it was better play. Oh, where's the yeah, the moment. The guy went yeah. He like got a red card. Like rat dog. Like I didn't get that. Yeah, I saw yesterday. Yeah, I don't know. No, sorry, I'm on. Yeah, yeah, you're right. Great idea. Everybody.
Just 1 hour fishing. Yes, thank you. Change of four piles.
Yeah, okay, that's better. Sorry. Now you blocked. Yeah. That's better. It should be when it like.
Anybody doing anything good this weekend?
Am I doing anything sunny? Sunny.
Study?
Yeah, it's awesome. Are you doing anything fun?
Kids, all the friends are coming over, so have all kinds of stuff ready. So we'll go anyway, pizza to me, barbecue everywhere. Yeah.
That's fun. I had.
Just relax.
Yours? Back going to birthday. Oh yeah.
I have the Xbox set up and everything, like to come to my house, I have big spoons set up and there's like TVs everywhere. So all their friends come over and it's like a party.
Oh, yeah.
They all play like Fortnite. I'm like, there's always one kid who gets a little upset. He goes and hides in the corner. My mom. So I have a 11-year-old and I have a 9-year-old. So
It's like good age.
yeah. So that's all they do. And then I have my 6-year-old daughter. So she just kind of hangs out watching.
Wait, no, you know where? Surgery. Wait, yeah, I know. That's exactly what was by the entrance. Is that the dive thing? I got the way. I know. Well, when we come in, the like bro, it's over there. I don't know. We come in. It's over there. That hall. Well, I'm gonna walk there. I'm pretty sure it's like, so when we're leaving, it'll be on the right. And I only know that. That I sprinted. Yeah. I'm pretty sure I know you're talking about. I mean, that's not, remember you beat me. I know we are. I don't know. Cardiac arrest. I don't think that. I know where the actual signal is. Oh. Yeah, I know that is. Like, right. I know where it's right. Oh yeah, I forgot about that. I don't know. I'm I don't have time to take a nap. Wait, oh my god. No, I have to go downstairs. I might go for a bike. I might go for a bike ride tomorrow morning. Wow, that's in Long Beach. No, I really don't like. You know what? I heard wisdom teeth taken out and no, after seeing that photo, I don't go anywhere near the bike. I was gonna go on the jump. I was gonna go on the jump like at like I that once I got so long after town. What really sucks? First time I feel it now. Yeah, like never. Yeah. Yeah, no, I mean, can I or like I like once I heard that song.
Say, what do you put?
It's like, oh, yeah, they don't answer it. then you think that would be like less. Alright. I actually yeah. So I got it. Wait. Now I feel like probably yes. Circulate. Yeah, that's I put a laptop first he was regular circulation. Is he in Quizlet? Yeah, but but you know it's good. Yeah, I love it. I like yellow. I have a butter. Couldn't do it. Yellow. Then there were no like, but I feel like when it's like nighttime, just like we've got yeah, like yellow sweatshirt. Wait, yellow is yellow is I was going to I got the yeah. And then I'm gonna look for now. There was an extra. Well, there was an extra. Well, like I just don't wish I could other Greg at night. I just like I get around like they drive around like yeah. Very because it's here and yeah. I ended up getting involved in the model with I'm scared that I think I get another mine like I like mine like here. But I got the math yeah. Might as well get whatever. Yeah. I wear like my mid like mine was like the eyes are like I didn't have any. They don't have a small. I was gonna small. I feel like the French. Yeah. Yeah. I do like I I like how they rate. Having that like, but I have 5 different sweatshirts. I don't wear. That's why I got that here. Yeah, I don't. Yeah, navy blue is my color, my favorite color, but I have everything I had. Oh, yeah, I just like a red. I can't really wear it. Yeah. Yeah, yeah. I found like yeah, and then dark horse, yeah, dark yeah. Brown, like oh yeah, light under. I have a now I feel like I can't find one thing I need to buy. Yeah, I do need a hair bra, like shit. Mine is a whole day and stuff in the next night. I just got a grass because yeah, so it was big. You say I'm real one. They just that. Oh yeah, they don't. They don't have I don't have a little some sort of yeah, I have one of those. I don't know. I feel like they don't. I never. I think they sound like I don't want to little something outside. Like I have nothing. I kind of pulls it. I don't think I like. Yeah. I no, right. I'm also really good at no. Yeah. I know that's I like to see my like there's t-shirts they're like nice. I don't know if they have. So I went to right. And like nothing on like all I have, like I really like not on the phone. She told me I was like, I'm not the answer to that. That's it's right.
All right, 15 more slides and I'll get you guys out of here. Next thing, PMR, polymyalgia rheumatica. This is a very important disease process. You're not going to see this too often out there, but it is available. This is seen in the elderly. Once again, it's only seen in the elderly. It is an inflammatory process that causes all kinds of indication or pain. The pain that these patients come in, they complain of shoulder pain and pelvic pain. Okay. They do have morning stiffness, which is prolonged, and over time it kind of gets a little bit better. But these patients, once again, there's an antigen that's floating around. Exact reason for why these patients have it, we don't know. There is a genetic predisposition. There is an infectious agent they're talking about, also gram-negative, but nothing has really been, and nothing in the journal is indicating that it is so the case. They're saying maybe it's not, but more studies have been done. Once again, genetic predisposition, absolutely. If you have an antigen called HLA-DR4 floating around, then there's a good chance that you are going to have polymyalgia rheumatica. Now, you're probably asking yourself, all right, well, if I do have it, what do I need to look for? How do I pick it up on the exam? Well, let's talk about that. Patients will come in, and then you probably tell you in the morning, I have a lot of stiffness and pain all alongside my body. All right, where is the pain? Can you point to it with one finger? It's usually in my shoulders and in my pelvic region is where the pain is. Is it in your lower back over here? No, it's not in my lower back. Therefore, it's not ankylosing spondylitis. It's mostly in my shoulders and my pelvic region. Okay. Pelvic region might be close to your sacroiliac joint, but shoulders are definitely not going to. The presentation are going to be combined together, shoulder and pelvic pain. All right. So there are different manifestations of this, and they present differently. We will go ahead and come back to this in a later slide. But for right now, understand that patients who have polymyalgia rheumatica often have something called giant cellularitis. And what that simply is your arteries in certain areas of your brain, well, not your brain, but your body will get inflamed. And once they get inflamed, these arteries will get inflamed, they will cause pain. Now, exactly where? Giant cellular arteritis, we tend to see in the temporal area, around the cranial arteries. So here, they'll complain of headaches, and you ask them exactly where the headache is, they'll tell you it's all around here, all around my head, around my temporal area. The symptoms are very straightforward. You're not going to see any different presentation, and therefore it's very key. If a patient comes in and tells you, I'm having scalp tenderness, you know it's giant cellularitis. And then it's your job to figure out the giant cellularitis and the patient has polymyalgia rheumatica. And I'll explain. They'll also complain of just generalized headaches and loss of vision on just one side. Now, can you have giant cellularitis in itself? Yes. Can you have giant cellularitis if you have PMR, polymyalgia rheumatica? The answer is yes. You can have this alone or you can have it with PMR. But I've never seen a case scenario or case vignette that does not have scalp tenderness, headaches, jaw claudication, blurred vision, or loss of vision. These are usually in these symptoms for anyone who has giant cellularitis. All right, let's go back to polymyalgia rheumatica now. So we know they're complaining of shoulder pain. We know they're complaining of pelvic pain. They're telling you that when they wake up in the morning, it's very stiff. Then they might tell you I'm also having headaches. They also might tell you they might have scalp tenderness. That's from the history. At that point, you'll know that it could be polymyalgia rheumatica, or they can have giant cellularitis. And then your job is to differentiate if they have both or just one. It's all right. I know what's coming on. I have two differential diagnoses going on in my head. Let's kind of move forward. I got a good history. I got a good physical on you. On a physical examination, obviously you're going to see the shoulder pain, hip pain, especially in the pelvic region, decreased range of motion. So your physical examination is out of the way. Next question is, all right, well, what do? Do I get x-rays? Do I get lab work? Well, let's start off with lab work first. You'll get something called ESR. And usually anybody who has ESR above 60 has a fundamental diagnosis of polymyalgia rheumatica. What do I mean by that? Well, if I took a bat and I swung and I hit you in the arm with it, and I got your ESR levels, they're going to be up. But if you have no mechanism of injury, you just wake up in the morning, you like have joint pain, and you get your ESR levels that are elevated, then it's going to be polymyalgia rheumatica. You get the idea? You have to differentiate between ESR levels and CRP levels. They are inflammatory markers. Alongside with that, LFTs, some anemia panels, and so forth, they can come back abnormal. But what I really want you to do is concentrate on ESR. There's a reason why I balded it and made it into a bigger font and so forth, so it stands out and you know exactly what I'm talking about. Now, the next question is, I have an ESR levels, I got a history, I got a physical, I need some other stuff. I need something more to diagnose this patient with. Not a problem at all. So what we're going to do is this. We're going to do a trial of steroids. We're going to give you a ton of steroids, and then we're going to wait for those ESR levels to come down. And then we wait. We recheck your ESR levels again. After steroid is done, your ESR levels will shoot right back up again, and that's your first diagnosis. Other ways of doing it is, obviously, if you have temporal arteritis, you can do a biopsy. And that will let us know if the vessels itself are inflamed, and they'll let you know, yes, you have a lot of inflammation alongside those vessels, it could be polymyalgia rheumatica alongside with the ESR levels are elevated. So this is a working diagnosis along the whole time. It's almost a clinical diagnosis, and that's the way we like to do it. You have to see what's coming back. So, what kind of steroids do you give? Well, you want to get steroids on right away because that decreases the complication alongside the vessels, especially around your temporal region. Because you could go vision loss if there's too much inflammation. So you want to put them on steroids and break down the inflammation so that vessels can open up, meaning your arteries can open up. You want to start the patient on 20 milligrams, between 10 and 20 milligrams of prednisone. Now, this is for someone who just has polymyalgia rheumatica. If you have polymyalgia rheumatica with temporal arteritis, then these numbers go up. Between 60 to 80 milligrams of steroids are given daily. Now, if you're thinking clinically, you might be like, whoa, this is way too much. Can the GI gut handle this? It might not. You might get diarrhea, you might get C. diff colitis, you can have all kinds of complications. This is high dosages. Initially, this might be given what? IV. You bypass the GI gut so you don't have a breakdown. But eventually, you're going to start being put on PO steroids. Okay? So, combination, higher dose. Just PMR, lower dose. Treatments are long. 1 to 2 years. Alongside with that, other medications like NSAIDs, DMARDs medications, disease-modifying anti-rheumatic drugs like methotrexate. And you can bounce back and forth, whichever one works for you. Sulfalazine, injectable gold. You remember all those stuff. Imuran, all those. It depends. Usually 2 years course is absolutely needed, but these patients have secondary problems all the time. Steroids at that level can cause all kinds of issues. What I mean by that is this: osteopenia, infections, GI complications, on and on and on. And most importantly, glucose levels going up and now cause secondary infections. So please keep that in mind. It's so important. Okay? Let's do Lyme disease and I'll let you guys go. This is pretty short. So, if you live on the island, actually, you know what? We'll leave this for next time. Thank you for coming down.
Yeah, thank you.
Because then we have like 50 slides next time, and then we're